Hello everyone. Today I'm going to deal about gastric tumors. So I'll just start with a video which will depict how the doctor faces difficulty in telling that the patient has cancer. So everyone, you have seen the video, right? So what do you understand by that? That the stomach cancers are detected very late. You can begin. See, in that video, the person is saying that he is just 37-year-old, he is non-alcoholic, non-smoker. His mom is fine eating what the food, the same food what he is eating, but still he got stomach cancer. So that means that, see, there can be a genetic basis, there can be some environmental thing which can lead to the addition of a mutation, then anybody can get stomach cancer for that, suppose. And the other thing you have to know from the video is that usually the stomach cancers are detected very, very late. For that, you have to do surgery. The prognosis depends upon the location and then various other things. So before I give a detailed thing about the stomach cancer, I just want you to know what we have discussed in the previous class, just a small recap of that. I could not play the video in between. So that's the technical problem. So that's the reason I'm starting with the recap now, and then we'll proceed to the stomach tumors. So the plan is I'll be discussing about hypertrophic gastropathies, benign tumors and malignant tumors after the recap. Right? So I told you there are four parts, that is cardia, fundus, body, and the pylorus, and various types of cells here. You can see the cardiac mucosa is having foveolar type mucus secreting epithelium and short tubular glands. And then here in the body and the fundus mucosa is the same, that is having parietal cells which will secrete the HCl, and the intrinsic factor, the chief cells or the zymosin cells which will secrete the pepsinogen, the endocrine cells. And here in the pyloric cells, you also have this mucus cells along the long tubular glands, and all. There are also gastrin cells which are like the enterochromaffin cells, which will stimulate the parietal cells to produce acid. And we also got to know one congenital lesion in the stomach, that is pyloric stenosis, right? So what happens when a person has a pyloric stenosis? It can be congenital or acquired. In the congenital, there is concentric pyloric muscle enlargement, narrowing the lumen. So what happens? The food won't pass, and it will cause pyloric obstruction. So the food won't pass into the intestine. And then what else you have to know is that there is visible peristalsis from left to right and projectile vomiting for the infant, right? So this is about the congenital pyloric stenosis. And coming to the equilibrium, how the acid produced is being tolerated by the stomach mucosa is by protective factors like mucus bicarbonate, the alkaline type, that is a mucosal blood flow, arterial barrier function, and the elaboration of prostaglandins. So any inhibition of these factors will lead to irritation of the gastric mucosa and inflammation, right? So what are the damaging factors? The damaging factors of gastric acidity, peptic enzymes, H. pylori, NSH, which will inhibit the prostaglandin synthesis, alcohol, and the reflux, right? So anything which impairs the mucosal blood flow also impairs the defenses, and that's how the damage occurs. So the damage can be in the form of an ulcer, forming a non-specific acute inflammation, granulation tissue, fibrosis, and with a necrotic base. So this is about the equilibrium, what maintains the equilibrium and what disturbs the equilibrium. Before we go into the other things, I told you itis is the gastritis is classified into acute gastritis and chronic gastritis, right? So the acute gastritis is again classified into acute H. pylori gastritis, acute infectious gastritis, acute other forms of gastritis like chemical gastritis, other things, right? So what happens in acute gastritis? When there is some impeding agent or a foreign agent which is trying to irritate the mucosa, the first change you will see is the presence of edema, neutrophils, and then if there is erosion of the surface, there can be hemorrhage. So it is called as an acute hemorrhagic gastritis. So that is about the acute gastritis. Now coming to the chronic gastritis. The chronic gastritis, what do you see? The repeated damage to the mucosa and the defenses are lost. Then what happens? There is some types of gastritis. Again, the chronic gastritis is classified into type A gastritis, type B gastritis, and type AB gastritis. You can remember it like this. The type B gastritis is the H. pylori gastritis. The type AB is like antral body gastritis, that is mixed of both. And type A for autoimmune. Okay, so what happens? There are autoantibodies to the parietal mucosa, so there is no intrinsic factor. There is atrophy of the epithelium, so there is atrophic gastritis. And you can demonstrate it by having some kind of other associated autoimmune regions like diabetes or something like that. Okay. So this is about the normal classification of chronic gastritis. But if we take the extent of inflammation, the activity of inflammation, and the metaplasia into consideration, again the chronic gastritis is divided into chronic superficial gastritis, chronic atrophic gastritis, gastric atrophy, and chronic hypertrophic gastritis, and others. So these 5 you have to remember. The chronic superficial gastritis, you know, it's superficial, it doesn't invade the muscularis, that's just by the definition. The chronic atrophic gastritis usually is associated with metaplasia, that is prepyloric metaplasia and intestinal metaplasia. And then the other one is gastric atrophy, usually will not see an inflammation. Then the other one is chronic hypertrophic gastritis, also called as MENETRIERS disease with hypertrophic muscular layer of the stomach. So I'm just giving a recap of what all we discussed yesterday. Okay. So after you get to know about the types of chronic gastritis, now it is the time to know there is some classification of the Sydney classification, which includes the location, the morphology, and the etiology together, in addition to the other things what we spoke about. So that is Sydney classification, which is essential to classify the chronic gastritis again. So just remember that there are many classifications, type A, B, AB, mixed, that's one, and the other 5 types based on the 3 extent of inflammation and metaplasia and the activity of inflammation, whether acute or chronic. And then there is a Sydney classification. And before going to that, you'll just see the most common infection, that is H. pylori infection after months, can cause it can be just an asymptomatic infection, or it can cause an atrophic gastritis. The duodenal or gastric ulcer is having a predisposition of more than 3 to 6 times than the normal person if the person is having atrophic gastritis. And then the gastric carcinoma, that is 3 to 6 times predisposed with dysplasia, and then being a precursor of the gastric carcinoma here. And then the non-atrophic pangastritis, which may cause proliferation of B lymphocytes, and these lymphocytes eventually may cause MART lymphoma. The normal, what is MART? MART is nothing but mucosa-associated lymphoid tissue that's normally present in the gut, which will protect the gut from any pathogens. So they'll proliferate, they react first, and they try to stop them. But then if there is continuous H. pylori which is there, then it cannot help it but transform itself into neoplastic, and this is 6 to 50 times more associated with the H. pylori infection. So that is what we have to know. And then we also discussed about the peptic ulcer. What is the peptic ulcer? There is degeneration of the mucosa because of the hypoxic ischemic injury and the mucosal damage that can occur to the stomach line. So what are the factors which are associated with it? Increased vagal activity, parietal cell hyperplasia, increased sensitivity of parietal cells because of excess release of the gastrin and histamine. Then because of that, what happens? There will be rapid gastric emptying. That means that you just eat food, you feel that it's acidic, and you would just want to go to loo. Then this is H. pylori infection, which can cause chronic gastritis, then lead to the ulcer. Then what are the duodenal factors? The duodenal factor is that there is decreased mucosal bicarbonate secretion. I told you bicarbonate is one of the protective factors to maintain the equilibrium in the stomach. So sensitivity of mucosa to acid injury, hyperacidification of duodenal bulb, decreases retrograde motility, which impairs the pancreatic alkaline secretions, and then the pancreatic secretions may not reach the duodenum. So these are the factors which are seen in formation of the ulcer, various gastric and duodenal factors. The gastric ulcer, I told you, microscopically has necrotic zone, superficial exudative zone, granulation tissue zone, and zone of cicatrization. Just remember these things, right? These are very, very important. That's the reason I'm just repeating them. And whenever I say ulcer, how can I differentiate it from a benign ulcer and a malignant ulcer? So this is a small ulcer, usually with punched out margin. And then the malignant ulcer is usually a large sized with a rolled out margin. Okay, usually the margins are irregular here. That's also another point you can just add to it. Okay, so this is the differentiating factor between the benign and the malignant ulcer. Right, what are the complications that can occur whenever there is an ulcer? Obviously, there can be some malignancy arising out of it. The transformation of the peptic ulcer to malignancy is absolutely very, very rare though. But you have to remember there can be hemorrhage, there can be obstruction, there can be bleeding or melena, hematemesis, nausea, vomiting, all related to the peptic ulcer disease. The main thing you have to remember, it starts with dyspepsia and then dysphagia. If it is a gastric ulcer, then you have to remember all just the plain symptoms. What happens to you when you eat any kind of spicy food? Just remember those things, and that will give you the complications. So how do you differentiate the duodenal ulcer from the of a gastric ulcer? See, usually the males are more prone, and then H. pylori infection is associated with gastric ulcer. Not that the duodenal ulcer, not that the gastric ulcer is not, but there will be disruption of mucous barrier. There is hyperacidity in duodenal ulcer. The gastric ulcer usually associated with normal and low acid production. You can see the hemorrhage and perforation can be more common with the duodenal ulcer. Perforation, if it happens to any ulcer, what happens? The contents will go into the peritoneum and will cause peritonitis, right? Inflammation of the peritoneum. And then malignant transformation is less than 1%. The most important thing is that you have a pain, you eat food, and then you are getting relief, that is the duodenal ulcer. And then if the pain is aggravated by food, that is the gastric ulcer. Usually there is night pain, and here there's no night pain. Vomiting is common, and then hematemesis is common with the gastric ulcer. So you have to just prefer a bland diet when you have a gastric ulcer. There can be seasonal variation in the duodenal ulcer and no seasonal variation with the gastric ulcer. So just remember these differences. So the thing is that we've spoken about the gastritis and peptic ulcer disease in the last class. Just a small revision about what I've spoken in the last class. Then coming to today's one, the hypertrophic gastropathies. What are they? They are very uncommon disease. They have the giant cerebriform enlargement of the drugal folds due to epithelial hyperplasia without inflammation. That you have to remember. There's no inflammation, but there is something that is trying to enlarge the thickness of the stomach wall, that is the epithelial hyperplasia. It is due to what? Excessive growth factors release. The two most common things are the MENETRIERS disease. I told you in that classification of extent and activity and the metaplasia. I told you there are 5 things, right? Chronic superficial atrophic gastric atrophy and chronic hypertrophic. So chronic hypertrophic is nothing but the MENETRIERS disease. And then there is another one called the ZOLLINGER-ELLISON syndrome. I've already discussed about it, but I'll discuss it again. So here you go. These are the gastropathies. And then you can see it's all middle age group, which is most commonly affected. In the MENETRIERS disease, the location is usually the body and the fundus, and the antrum is relatively spared. And the predominant cell is the mucus cell, which gets hyperplastic. There are limited lymphocytes. See, whatever inflammatory cells we're talking about are very less in number. That's the reason why they're called as gastropathies. They're not, the thickness is, or the hyperplasia is not a result of inflammation. So the risk factors are none, and association with adenocarcinoma is present in MENETRIERS disease. The Zollinger-Ellison syndrome, you know, the parietal cells are more commonly involved than the mucus and the endocrine cells. And I've told you it is associated with multiple endocrine neoplasia, type 1 usually, that is the men, right? The inflammatory and hyperplastic from here, that is the inflammatory, hyperplastic, gastritis cystica, fundic gland, polyp, gastric, all these are as a result of the epithelial hyperplasia falling a polyp. A polyp is nothing but a finger-like projection which just protrudes into the lumen. It can cause obstruction, it can cause inflammation, and all that. So from here, these 4 are one example of different types of the polyps, which I'll discuss in detail, right? The predominant cell type, again, like the MENETRIERS, is hyperplastic polyp, is the foveolar epithelial cells, which produce a mucus. Then you have to know the hyperplastic polyps are usually associated with chronic gastritis and H. pylori, Helicobacter pylori. Okay, they are very, very occasionally associated with malignancy, but not always at all. The gastritis cystica, it is A actually. So there is a mucocystic lining here. This is as a result of trauma or a prior surgery. The fundic gland polyp usually seen in the body and the fundus with epithelial hyperplasia of parietal and chief cells. It is usually seen in patients who are taking more of proton pump inhibitors. And there can be an association with FAP, that is a genetic association that is called as familial adenomatous polyposis. Okay, then gastric adenoma. It is usually more common in the antrum, usually dysplastic, and can be associated with chronic gastritis. FAP is familial adenomatous polyposis, and intestinal metaplasia. So we're talking about 6 gastropathies here, wherein 4 are polyps and MENETRIERS and ZOLLINGER-ELLISON syndrome we have seen. So this is a gross picture of the MENETRIERS disease. The name implies there is chronic hyperplastic tissue. So you can see there are hyperplastic buccal folds here. They're not normal, they're just hyperplastic. Then you can see in this HD picture wherein you can see the foveolar hyperplasia. This is the epithelium which got hyperplastic. And then here you can see this is a gland which is dilated. So this is what you're seeing here, this microscopy and gross appearance of the MENETRIERS disease. Then coming to Zollinger-Ellison syndrome, this is the syndrome caused by gastric tumors, that is gastrinomas. I told you the G cells will increase, they will try to produce more acid by giving a stimulus to the parietal cell. So what happens here, there is doubling of xanthic mucosal cell thickness, so the increase in number of parietal cells. So there is increase in G cells which will try to go and hit the parietal cells, come on work. Then gastrin also induces what? There is hyperplasia of mucous neck cells, obvious, mucin hyperproduction and proliferation of endocrine cell. That's the reason why I said in the table, if you have seen, in the Zollinger-Ellison syndrome, the parietal cells are more proliferating than the mucous endocrine cells, but these 2 cells are also proliferating. Okay. So what is it? Association with men. Clinical features, these are important. So anybody coming with epigastric pain, you can't just send them for Zollinger-Ellison syndrome checkup, or you should have these things. Heartburn with GERD, acid hypersecretion with diarrhea. And you do a lab investigation like basal acid output by maximal acid output, and that is increased. The serum gastrin level when you check is more than 1000 picogram per ml. In the secretin stimulation test, we'll have serum gastrin level more than 200 picogram. I've told you in the last class about the basal acid output, that is you measure the baseline acid output first, and then you try to stimulate the stomach, produce more acid, then you check, that is a maximal acid output. So coming to the classification of gastric tumors and tumor-like lesions, the tumor-like lesions are also called as polyps, that is hyperplastic polyps, hematomatous polyps. The benign tumors are epithelial and non-epithelial. In the epithelial, you have to remember the adenomas. And the non-epithelial, you have to remember gastrointestinal spindle or the stromal tumor called as the gist. In the malignant tumors, there are 4 you have to remember: epithelial, non-epithelial, carcinoid tumor, and the lymphoma. In the epithelial, there is adenocarcinoma and other uncommon carcinomas are also there. And in non-epithelial, there is leiomyosarcoma and leiomyoblastoma, the carcinoid tumor, and the lymphoma. See, whenever, whatever the system is, you just have to know what is the classification to know what kind of disease any stomach will have. So when a patient comes with certain complaints, you can just without any investigation say that the person is having this kind, may have this kind of a thing, and program an investigation so that your assessment will be right. So what is a polyp? They're nodules or masses that project above the level of the surrounding mucosa. They are finger-like. Okay, they're just the protrusions. They go into the lumen. Then they are identified up to 5% of upper GI endoscopies. The polyps may develop as a result of epithelial or stromal hyperplasia, inflammation, ectopia, or neoplastic. So there can be, these polyps can also be a complication of inflammation like chronic gastritis and achlorohydria. Hyperplastic polyp is the most common type. Hematoma with no malignant potential, and adenomatous polyp can be a neoplastic polyp with the potency of transformation into malignancy. So 75%, so almost all are hyperplastic or inflammatory polyps as a result of chronic gastritis or anything which irritates the mucosa. Okay, the H. pylori gastritis is usually associated with hypoplastic polyps. I've already told you while I was discussing the table. Now, coming to the risk of dysplasia. So, do you think any polyp should be resected? Not really. So, what polyps are to be resected and looked for? These polyps, which are more than 1.5 centimeter size, should be looked or examined histologically for any dysplasia or malignancy. So the hyperplastic lesions, they are not, just to give a gist of it, they're usually occurring in pyloric antrum. They are single, sessile or pedunculated. See, they are usually single, they are multiple, they may be associated with any syndrome, sessile and pedunculated. If it has a stalk, it is pedunculated and sessile. If it is not having the stalk. So microscopically, they are hyperplastic glands and do not have malignant potential. Hamartomatous polyp, the classical example is juvenile polyp and pancreatic heterotopia and Oesophagus syndrome. These are just the malformations, they are just increased by birth or during the birth. There may be a part of the tissue which is just more formed. So that is the hamartomatous polyp. So this is a picture of the hypoplastic polyp. You can see there is a little inflammation and then edema. Okay. This is the finger-like projection we are seeing here. See? Okay. And then here the hypoplastic polyp picture is shown with the areas of ulceration. Then coming to the other one is funding gland polyp. The funding gland polyp is usually associated with FAP, that is a familial adenomatous polyposis. I already told you this. Usually seen in patients taking the proton pump inhibitor therapies. What happens here? There is gastric acidity, gastrin secretion, and then there is glandular hyperplasia. So this is, as the term, this is more seen in the fundus and more seen in the woman. So usually it is asymptomatic. If it is more or if it is associated with any symptom, it is usually the nausea, vomiting, or the epigastric pain. So this is a hypoplastic. You can see this is an example of the funding gland polyp. You can see that this is a dilated gland. Okay, and then this is gastric adenoma with dysplasia. This is a finger-like projection. You can see there is pseudostratification here. Okay, what is stratification? Is proper formation of layer by layer, the cells. But pseudostratification is that they are not actually stratified because of the placement of the nucleus. They appear stratified or layer, usually associated with dysplasia. So, after finishing we've spoken about the gastropathies, that is the MENETRIERS, ZOLLINGER-ELLISON syndrome, hypoplastic polyp, funding gland polyp, then adenomatous polyp, and gastritis cystica. Okay. All the 6 things you remember, then you have to know what is polyp, the size of the polyp, why it has to be examined histologically, everything. Okay. Now coming to benign tumors. The benign tumors can be epithelial, non-epithelial. Again, the epithelial, there are adenomas, that is proliferation of epithelium, the glands, the stroma. The stromal or non-epithelial tumors where it can be just a leiomyoma, the smooth muscle tumor, or a schwannoma, neural tumor, or a cyst. Okay. Then coming to adenomas, these are most commonly situated in the antrum. Okay. They are associated with atrophic gastritis and pernicious anemia. Cysts are most common site is also stomach, but cysts can also occur elsewhere. Okay, behavior is generally benign, but may be recurrent, aggressive, or even metastasis may occur. So, coming to in detail about the gastric adenoma, males are more commonly affected. If you remember all the ulcers, duodenal peptic ulcer most common in males. The funding gland polyp that is most common in women, right? So, incidence of adenomas is increased in individuals with FAP, that is familial adenomatous polyposis, like that of funding gland polyp. Even the funding gland polyp is in relation with familial adenomatous polyposis, the same way the adenomas also. Okay, they can occur in background of chronic gastritis with atrophy and intestinal metaplasia. See, when I talked about hyperplastic polyp, I spoke about the presence of the background having chronic gastritis or H. pylori. So in gastric adenoma, the precursor to formation of adenoma is also chronic gastritis and atrophy, but with intestinal metaplasia. Remember that. What is intestinal metaplasia? Remember, while I discussed about Barrett's esophagus, I told you the differentiated tissue, that is the intestinal tissue, is coming and sitting at various places like esophagus or stomach. If it is in the esophagus, then it is called as Barrett's esophagus. It is identified by the presence of goblet cells. So here the risk of adenocarcinoma is particularly elevated in lesions greater than 2 centimeters. And I told you the polyps which have to be examined if histology clear, if the size is more than 1.5 centimeters. Here I'm not sure, but if it is more than 2 centimeters, there may be adenocarcinoma in the patients having that adenomatous polyp. Okay. So coming to the morphology, usually they are solitary, less than 2 centimeters in diameter. If it is more than 2, I should be suspecting something else. In microscopy, it can be sessile, that is without stalk, tubular or tubular-villous, representing the intestinal mucosa. And then usually the adenomas, you know, are lined by the columnar epithelium and are just classified into low-grade dysplasia and high-grade dysplasia. So by definition, the adenomas may have the dysplasia. So both the grades, that is a low-grade dysplasia and the high-grade dysplasia, have what? The cellular enlargement, elongation, hyperchromasia of epithelial cell nuclei, epithelial crowding, and pseudostratification. So while I was showing you the picture, there is a polyp-like projection, there is pseudostratification. I already told you what is pseudostratification. Then dysplasia featured by hyperchromasia, enlargement of the cell, and then epithelial crowding. Remember this is common for both low-grade dysplasia and also high-grade dysplasia. But what else we have to see to consider it as high-grade dysplasia is that we have to see severe cytological atypia, irregular architecture, including glandular budding, gland within gland, or cribriform structures. See, if there is uniformity, for example, if we are seeing normal cells, imagine you are seeing school students with the same uniform, the same height, everything is same, then that is usually normal structure. If you are seeing a carcinoma or a dysplasia, you can see the arrangement will be, some will be tall, some will be short, some will be wearing a uniform, some may not be wearing a uniform. You know, I'm just giving you an example to know how the cells are arranged. So if they're uniform looking and all, they're usually normal. In benign conditions, they look normal, but there are more cells. But here in dysplasia, what happens is that the students, for example, if they're attending a prayer or something, if you, in our school, there used to be civil dress on Saturdays, like, you know, so on all other weekdays, we used to wear only one uniform. So that means they're all, the cells, if you're thinking in terms of students, they're all uniform. Okay, if on Saturday you think that should be an example of how you can describe a malignant tumor, one short, one long, and they're not wearing the same dress, some are wearing jeans, some are wearing something else, you know, like that. And gland within gland, so one gland within the other gland. So, and there is severe cytological atypia and cribriform structure. What is a cribriform structure? Cribriform is nothing but sieve-like, you know. Sieve is nothing but, it is, you know, you pour the tea, you strain the tea powder, right, before you give to your mom or dad. So that is the sieve which we use, the strainer. So that kind of arrangement will be seen in high-grade dysplasia. So coming to the malignant gastric cancer. See, the most unfortunate part about malignant gastric cancer is that it is usually diagnosed late and we can do very less about it. In that video, you've already seen how difficult it is for the doctor to tell the patient that you have cancer. Though we are we are in a profession where all the gastric cancers and the rare types of gastric cancers are reported, and we pat ourselves back and say that, you know, I have reported this. Pathologists usually do that. Okay. So gastric carcinoma is a leading cause of cancer. The leading cause is now about to decrease. Then peak incidence is 4 to 6 decade. More common in men than women. Okay. Now coming to etiology, H. pylori infection, I already told you, can cause mutations, can cause proliferation of the B lymphocytes, can cause myeloma, or it can cause a gastric adenocarcinoma. Then coming to the dietary factors, the nitrosamine, smoked foods, all this can cause the gastric cancer. Geographical factors, that is Japan and Kyle, they're more used to having smoked foods and they have more propensity to have a gastric cancer. Then genetic factors, for example, there is something called as CDH gene, which codes for E-cadherin. What is E-cadherin? It is the cell binding thing. Like, you know, if there is loss of CDH, the tumor suppressor gene, there is no E-cadherin, the cells will try to separate. There is something which is joining the cells, and then cells try to move away from each other. So because of that, what will happen? There can be more metastasis for a poorly differentiated carcinoma, and that will lead to a diffuse type of gastric carcinoma. Okay, so here we see what are the clinical features. See, the clinical features are usually like that of the gastritis. You just have an ulcer or dyspepsia initially and the early gastric cancer, but in the advanced stage you may have weight loss, cachexia, altered bowel habits, anemia, hemorrhage, and other things. So I already told you about the most affected areas and then risk factors because of reduced use of smoked food. Okay. Are there any foods that prevent cancer? Yes. So they are green leafy vegetables, citrus, antioxidants, vitamin E, beta carotene can reduce the risk of gastric cancer. Not just gastric cancer, in spite, to be frank, can give us immunity and you know, help us be a better individual, healthy. Right? Morphology. So the gastric carcinoma commonly located in pre-pyloric region formed by the lesser curvature, pylorus, and the antrum. So usually, I also told you there are two types, that is intestinal type and the diffuse type. Okay, the types of gastric carcinoma. So in the same way, morphologically, we can divide the gastric carcinoma into early gastric carcinoma, wherein it is the early does not signify the time. Early signifies that the lesion is just confined to the mucosa or the submucosa. Then coming to the advanced gastric mucosa, it is just that it's just going deep. There can be metastasis, that it can be infiltrating, right? So the gastric carcinoma, the conventional classification is early gastric carcinoma, advanced gastric carcinoma. And the classification based on the depth of invasion is expanding carcinoma and infiltrating carcinoma. Okay. So here there are the 5 major gross types: ulcerative carcinoma, fungating carcinoma, scurous carcinoma, colloid carcinoma, ulcer cancer. See, I can do nothing about, but you just have to remember these names and how they are. I'll give you a detailed description of each so that you just remember what they are. Now, coming to the extent of invasion, there are 2 types of cancers. One is expanding, the other one is infiltrating. What is expanding? There is a margin. The tumor cells are arranged in cohesive clusters. That means your group, your friends all together are trying to go and hit one person. That is expanding carcinoma. Infiltrating carcinoma is like zombies. You know, if you have watched that movie World War Z, then each zombie is trying to go and have food for itself. So infiltrating carcinoma, that means you're going just singly and then fighting everyone. So that is with a poorly defined invasive border, that is infiltrating carcinoma. So tumor cells are loose here in infiltrating carcinoma and invade singly or in small group. So just a picture, early gastric cancer. Here you can see the mucosa and the submucosa. See, there are layers: the mucosa, the submucosa, muscularis, and the serosa. Okay, these are the layers of the stomach. If the mucosa and the submucosa are only involved, this early gastric cancer, obviously if you resect the tumor at this point of time, the patient has very good prognosis. Now coming to the polypoid carcinoma, this is a cauliflower-like growth protruding into the lumen. It can have a depth and there can be a lymph node metastasis. So this is the polypoid carcinoma. Now coming to the ulcerating carcinoma, the name just implies there is an ulcer, the tumor is growing inside, so obviously there will be metastasis. The serosal invasion can be seen in ulcerating carcinoma. Infiltrating carcinoma, I told you, Linetis plastica, all these cells are called as signet ring cells, and then there is thickened fibrotic mucosa, and then can extend into all layers. I told you, remember the zombies, okay? So in Linetis plastica, the cells are single, loose. Each cell is having more cytoplasm and pushing the nucleus to one side, and then it is giving a signet ring appearance. I'm sorry, I'm not wearing a ring, otherwise I'm sure I've shown you how the ring will be. The ring, if whatever you're wearing, will have the nucleus pushed to one side. If you think that the pendant or whatever God's thing is there, you know, that's to one side. So nucleus is to one side, and the round, the cell and cytoplasm to other side. That's the signet ring cell carcinoma. So the early gastric carcinoma is also having patterns. Just remember, there is something called as polypoid, superficial elevated, superficial flat, superficial depressed, and ulcerated types. Just remember this, but just you have to remember, our early gastric cancer has a better prognosis, obviously, because it's not involving the deeper layers. Now coming to advanced gastric carcinoma, that is ulcerative fungating serous colloid ulcer cancer. See, ulcer cancer is not having any specific features, just adenocarcinomas, and there are just malignant lesions. Colloid is usually common in fundus. Colloid is nothing but mucin. Okay, there are pools of mucin. Imagine yourself swimming in some swimming pool. So the cells are just swimming with 2 or 3 people around. It's all mucin. So that is colloid carcinoma. Okay, the cells are again signet ring cells here. The serous carcinoma is a Linetis plastica or leather bottle. You go to a desert, you want to drink water. Usually, you know, in movies, you will be seeing that those kind of bottles, right? So this is a leather bottle, usually seen in pyloric antrum. Adenocarcinoma or signet ring cell carcinoma can be associated with serous carcinoma. Serous is like fibrotic, you know, thickened leather bottle, how it looks. Remember that. Fungating carcinoma, it's the cauliflower-like growth, usually a well-differentiated and papillary. See, cauliflower-like growth, usually wherever it is. The cauliflower-like growth can also be seen in penile squamous cell carcinoma. There also it is polypoid. And here you can see adenocarcinoma being a papillary type. So morphology, we use words just to describe. You just have the concept and then you can write anything. Okay, ulcerative carcinoma is the most common pattern, and it has obviously ulcer, you know. So it has to have a necrotic base. Usually they are poorly differentiated carcinomas. Just remember, ulcerative, ulcer cancer, fungating, serous, and colloid carcinomas. 5 advanced gastric carcinomas. So just the explanation here. See, you can see this in the pyloric antrum. You are seeing the early gastric cancer, limited to just the mucosa. And here the ulcerative carcinoma, it is trying to block the pyloric canal, so it is having an obstruction, gastric outlet obstruction, example of acquired pyloric stenosis. Here you can see a poorly differentiated carcinoma, fungating or a polypoid carcinoma, usually papillary adenocarcinoma and well differentiated. You can see this picture, the finger-like projection. See, it's like a finger, right? And then serous or Linetis plastica, which is diffuse growth of the wall, and then there is a kind of desmoplasia here in the signet ring cells, right? So now coming to colloid mucoid carcinoma, I told you, remember the swimming pool, there are mucin pools and the cells are floating, right? The ulcer cancer, the tumor in the ulcer, and there is adenocarcinoma with the necrotic base, no specific feature, remember that. Now this is the protruding mass of an adenocarcinoma. This is a gross picture, and here you can see there is plastic cells, okay, in the malignant glands, right? Here you can see the thick end, very thick. See, these rugae are lost here and this very thick. So this is the example of the signet ring cell carcinoma. Here you can see it's like a ring. No? This is the nucleus and this is the vacuolated cytoplasm. Right? This is called the signet ring cell. So here the carcinoma again, adenocarcinoma. This is a heaped up mass with an ulcer. And then these are the adenocarcinomatous cells. You can see they are anaplastic. You can see the prominent nucleoli. This is a nucleoli. This is a nucleus. See, this one is a nucleoli, right? So again, you can see the thick end one. And here you are seeing this is the diffuse gastric carcinoma. This is the intestinal type. And here you can see the signet ring cells. So I already discussed about differences between benign and malignant ulcer. They are usually in lesser curvature, the greater curvature. The size is small, the shape is regular, and malignancy, it is irregular. The mucosal folds are radiating, here it is interrupted. The ulcer bed is hemorrhagic, malignant ulcer, it can be necrotic. It is punched out in barium studies, it is irregular filling in malignant ulcer. The acidity is normal to low. Malignant ulcer usually normal. The therapy, what we have to do is the response to therapy is very good in a benign ulcer. In the malignant ulcer, obviously it's not good. So just remember that the margin, how the ulcer is, there is hemorrhage with the benign ulcer, the margins are regular, and then if the mucosal folds are radiating, the ulcer bed is hemorrhagic, punched out in appearance of the benign ulcer in the barium studies. All this differentiated from a malignant ulcer. So how is the spread? The spread is by the direct lymphatic and the hematogenous spread. Involvement of the left supraclavicular lymph node is called the Pitchaw's node or Troisius sign may be present. Presenting feature of gastric carcinoma. For example, a person thinks that he is fine, there's nothing wrong. Then he suddenly develops left supraclavicular lymph node. Then if you examine the lymph node, you find adenocarcinoma deposits in that. Then usually the left supraclavicular lymph node, if the patient is having any cancer deposits in that to adenocarcinoma, then you have to think about the gastric cancer. If the person is male, and then with the predisposing factors and all taken into consideration. So that is the sign of having a large lymph node is a Troisius sign, and the node is called as a Pitchaw's node. Okay, clinical features: abdominal pain, gastric distension, cachexia, and anorexia. So what are the complications? So once there is gastric carcinoma, the gastric cancer cells can just pass into the peritoneum and cause peritoneal metastasis. They can go into the lymph nodes and surround the umbilicus, and all the lymph nodes may get enlarged. And then the Pitchaw's node, I already told you, the supraclavicular node, the distant organs it can go and affect them, that is the liver. Then coming to the metastasis, it can also metastasize to the ovaries, then it is called as, replace a normal ovarian stroma, then it is called as a Krukenberg tumor. So you have to remember the spread is lymphatic spread, or hematogenous spread, or spread to the local organs, obviously. So the spread, if it is to the peritoneum, it is the peritoneal metastasis. The lymph nodes, the umbilicus will get enlarged, Pitchaw's node, distant organs, and the Krukenberg. Okay, so the complications also include the paraneoplastic syndrome caused by, see, what are paraneoplastic syndromes? The cancer itself is not causing the disease, but either the cancer cells are producing some of the factors which are going elsewhere, not in the tumor area, but going elsewhere and acting and causing a syndrome. That is known as a paraneoplastic syndrome. So it's not necessarily a metastasis, right? So what do you see? There's a lesser triad sign. Usually there are hyperplastic keratinocytes which are proliferated. Because of that there can be seborrheic keratosis. Because of what the keratinocytes are proliferating, there are some growth factors which are released by the cancer cells of the gastric tumor. So that is the lesser triad sign. Coming to other one, that is a polyarthritis nodosa. It is because of the inflammation and necrosis of medial arteries. So there can be kidney failure or a myocardial infarction because of PAN, right? So all this because of the gastric tumor cells are producing substances which will cause the inflammation and necrosis of the medium-sized arteries, which are placed at different size, right? And that can cause a kidney failure or myocardial infarction. The other one is atrocious syndrome, that is a migratory thrombosis. The migratory thrombosis is nothing but the cancer cells that will release a tissue factor that will cause activation of the coagulation cascade, and that will cause a thrombosis formation. So that is atrocious syndrome. So this is another syndrome which will be associated with gastric tumor. Then I already told you that if the tumor is present here, there can be a gastric outlet obstruction, or if it is present at the cardia, then it will cause a pseudoachalasia syndrome because of the obstruction or constriction of this, and there can be a dilation of the esophagus, and food is not allowed to pass into the stomach. So the other types of the gastric cancer, other types of the cancer or the tumors that can occur in the stomach are the leiomyosarcoma. This is stromal tumor of the smooth muscle, leiomyoblastoma, which is otherwise called epithelioid leiomyoma, carcinoma tumor, and lymphomas. Okay, I'll discuss about all these things again, but now coming to the symptoms. So a person comes to you with gastric, with some dyspepsia or dysphagia. In addition to that, he may give signs like seborrheic keratosis, and then polyarthritis nodosa. There can be atrocious syndrome, acanthosis nigricans. Acanthosis nigricans is nothing but darkening of the armpits, atrocious sign, that is enlarged Bichos node, and then dysphagia, difficulty swallowing, and when there is a metastasis because of enlarged belly button lymph nodes, that is called a Sister-Mary-Joseph sign. So you have to remember very, very important question for your PG entrance examination also, that is Sister-Mary-Joseph sign is just the belly button lymph node which gets enlarged because of the metastasis of the gastric tumor. I will take the lymphomas, the carcinoid tumor, the GIST, and others in the next class. Thank you so much for listening. Please go, just open your books and just go through what all I had said, and we'll have a little quiz again. And I want all of you to participate and then answer my questions. And then we'll discuss about the lymphomas and the other tumors associated with the stomach on Monday. Thank you.